Welcome to the next episode of Endoscopy Essentials. And I'm very happy to introduce Roos Pouw from Amsterdam. Welcome, Roos.
Thank you, Thomas. I'm very happy to be here.
Before we go into details about Barrett's and all the things which move you, maybe you tell us a little bit about yourself. Mm-hmm. Congratulations, you have been elected as the next UEG General Secretary, correct?
Yeah, yesterday, fresh off the press.
Yeah, that's mid-October now. Yeah. And do you come from a medical background? Was your family involved in medicine, or how did you get into medicine?
Well, I don't have a medical background in my family, so I was born in the Netherlands from a German and a Dutch father, a German mother and a Dutch father. Mm-hmm. And my mother, she's a teacher. So she taught elementary school in Germany, but when she came to the Netherlands, she became a German teacher in high school. Mm-hmm. And my father, he's like a manager. He's managing different companies, but there's also, in looking back in the rest of the family, there's no one medical at all. And somehow I was, when I was deciding what I wanted to do, I didn't really have anything other in mind than becoming a doctor. And I really thought about why, but I never really figured out why. But I just wanted to become a doctor because I thought.
And that started when?
I think when I was about 14 or something. Ah. And I thought it's just like people are interesting, the human body is interesting, and being able to mean something, contribute something to someone's life. Sort of was the incentive for me to go study medicine. And I think once I started, overall when I start something, I just find it interesting. I want to finish it. With medicine, that was the same.
So when you entered medicine, was it as you envisioned? Because it starts with physics and chemistry and all that school-like stuff, huh?
Yeah. Well, I have to say it, when I, like the first year, it's a little bit of everything. And then it's the first year you start studying and you don't live at home anymore, so the whole year is of course nice, like it flies by. You do some study and some, but I think I would have enjoyed it anyway, no matter what I had to study, because there were so many nice other things we also did, or I also did during that year. But then after a year, you got in the Netherlands, you got more themed-based learning, so gynecology. Gastrointestinal surgery, so it became very theme-based very quickly and very case-based. So that was a new thing when I started studying, that they wanted to, make it not so theoretical, but really have a case and a patient and then work from there. And also in our third year, we already started doing clinical rotations. So you got in contact with patients and clinical thinking really early on. And that just gripped me. I think I liked really every rotation I did. I thought, I want to become a surgeon. I want to become an internal medicine doctor. Only gynecology really was no match, but the rest, everything was really interesting.
Well, I think an early exposure is good, because in my system, which is a long time ago, we started like at school. It was physics and chemistry and anatomy and the first 2 years. And then the exposure to patients was during an elective period where we had to work as a nurse. So I think the first encounter with patients is where it's decided, right?
Yeah. Mm-hmm.
Whether you can do this or not.
Yeah, whether you want to. And I think there were also some colleagues who thought, well, maybe this is not for me. And then I think it's really good to find out early on, before you study really hard all the theoretical knowledge and the physics, etc. And I think the variation was nice, because then you also need the physical background to understand everything. But it just, at least in my opinion, made it much more fun. Yeah.
I mean, you are a role model yourself now for young female gastroenterologists. So when you finished your studies, then you started right away at the AMC in Amsterdam?
Yeah, that was an interesting story, because I never really... So I knew I wanted to do medicine very early on, and I didn't have anything other in mind. But gastroenterology was,
Not on the list.
Not on the list at all, and it's something we also didn't do during our studies, because it's often either part of surgery or part of internal medicine, but like really gastro rotation, at least when I studied, was not possible. And I think I wanted to become a surgeon during my last year because it was very like practical. You could work quite autonomously, like by yourself, and you could treat patients on the ER. And then during my last rotation, it was on the mixed ward, gastroenterology and surgery. And then I thought, the gastros, they diagnose, they can treat, they can follow the patients, and whereas the surgeons, they sort of just they do more, but like if you cut it down, they're mainly there for the surgery. So that's when I thought, well, I want to do gastroenterology, and I discussed this with the guy who was doing the training for surgery, and he brought me into contact with Bas Weuster, who was a gastroenterologist in the Netherlands, Nieuwegein, Utrecht, where I studied that area. He said, well, I might have a PhD spot for you, but you have to start right away. And I was still going to Boston for 6 months on a scientific internship.
So that was basic science? Yeah,
it was on...
what did you research on?
Liver transplantation in rats, and how to make it. It was a project of someone else, and I was just for 6 months. We operated on rats, took the liver out, put them in a perfusion system to see if you could prolong like the time you can transport them, etc.
Already some mini surgery.
Yeah. And so that was 6. It was really interesting, but really not. There was a lot of basic science as well, like microscope and coloring. And that was not really my. I like the practical stuff more. And then he said, well, I know a guy in Amsterdam. He does something with Barrett's esophagus. Maybe you should go talk to him. So the day before I went to Boston, I met with Jacques Bergman at the AMC. It was actually the day they did the first radiofrequency ablation in the Netherlands. And I was...
So before you went to Boston, you already had some conversations and negotiations with the job you would take on later.
Yeah. And then 1 month before I flew back, I emailed him, do you still have a position for research? And he said, yeah, you're welcome if you want to start. So
okay.
That's how it happened.
So maybe you tell our audience a little bit about the Dutch system, because there are fellows coming in, they're doing a PhD. They don't do much practical work in endoscopy, but they are studying, they're learning research, right? Mm-hmm. How is that financed?
Yeah, how is that financed? Yeah, it's it differs. So most after the study, you can either start your specialty training right away, or you can decide to do indeed full-time PhD, which takes about 3 to 4 years. It's mainly studied either by funds, a cancer fund or a fund from the government that you have to apply for as a PI, and then you can finance a research fellow. And there's also like grants from industry. For example, if they want to test a new product, you can say, well, I can set up a study, but we need financing for a research fellow. And I think it's a good system because you have someone really dedicated to the project. So they are sort of project managers, they write the papers. It's a really nice thing to do when you're just finished your studies because you're relatively young still. You get some experience in doing research. And
it's a very early exposure to clinical research, which is mostly missing because in other scenarios, mostly research is basic research and separated from the clinical duties. So people go into clinical work and then they, I wouldn't say they are lost for research, but they are going a different way.
Yeah.
But that's, if I understand correctly, that's not part of the hospital paid system. So you don't have positions from the hospital. It's financed through research money acquired by funds or industry support, etc.
Yeah, that's correct.
So how many of those guys do you currently have, let's say, in Amsterdam? Many. Huh?
Ooh, a lot. Yeah, it depends a little, of course, because there's the field is really rapidly moving. So sometimes there's more on diagnostics and sometimes more happening in the therapeutic fields. But all in all, I think our whole department, there's about 40 research fellows walking around. In our esophageal research group, we have about about 16, depending who you count in. But there's always large numbers of research fellows around. Yeah.
And when you started, there was still RFA, the big radiofrequency ablation, the big topic?
Yeah, so it started in 2006, and then it was indeed the early days of endoscopic resection. So one of the first studies I was on different endoscopic resection techniques, and it was indeed the time when radiofrequency ablation was introduced for Barrett. So that was the main focus of my PhD project. So we did the first studies in the Netherlands and the first European studies. So that was the big thing, at least for me at that time.
So when you came, you were present at the endoscopies, I guess, and speaking to patients and following them up. So you had clinical exposure.
Yes.
But you were not working on the ward.
No, it's
night shifts.
No, it's quite flexible. You just had to attend the endoscopies, talk to the patients, and in our team we had specialized nurses who did a lot of the patient care. So it's mainly attending the endoscopies, filling out case record forms, keeping the database up to date. But if a patient had a complication or something, it was really on the clinical people to take care of that. So that's not something we had to do as research fellows.
But you're not allowed to touch a scope, or is that... Are you licensed as a doctor already?
Yeah, you're licensed as a basic doctor, but you don't have any specialty training yet. So usually you don't do, at least not endoscopy. No.
Because in our German system and in many others, it would be unusual if young people come, after medical training and go into a specialty. Some do internal medicine training, but others go directly into gastroenterology. They're expecting to be able to touch a scope. So how do you motivate these guys? Or is it just part of the system and everybody accepts?
Yeah, I think it's part of the system because we know we cannot touch the scope when you start. And you don't have to do a PhD to go to training. So I think the people who decide they want to do a PhD are either intrinsically motivated because they just want to focus on something and don't want to go into the serious business of specializing, just a few years maybe of a bit more flexible time before you start, and maybe even decide if that's the direction you want to go. And in the Netherlands, it's also a little bit depending on what specialty that you need a PhD to be elected for a specialty training. There's a little bit of movement now, but for example, in our department, we have a lot of very talented PhD research fellows. And then if you have 10 very talented people, they're all very good. You've known them for 4 years. And you have only 3 spots to train people. It's people who do not have a PhD, they have no chance of getting in.
So that's the entrance door.
Yeah.
Clinical research is the entrance door.
Yeah, it's changing a little bit around the country because people feel that the PhD has to be fun and not something you do just for your curriculum vitae, but really something you want to intrinsically do. But at least our fellows, I think they like the fact they can focus, and it's always a nice dynamic group.
It's interesting because, as we both know, there are very different medical systems. But the Dutch system, at least in my country, and I think in many others, is always given as an example about clinical research. But what people may not realize, the system is very much focused on that. Yeah. So you start with clinical research. And I think maybe that's the secret of the whole thing, that your entrance door is clinical research. So your mentality is probably formed differently. Rather than if you go into a system where you start working and then basic science is the thing where people have to go. Yeah. So I hope people are listening.
Yeah, and I think it's correct. Not everybody keeps continue doing research, but if you really like the clinical research and you learned the basics and the statistics and how you should do a good study, and you like it, like in my case, I continued doing research during my training and afterwards, and it's much easier if you've done it for a long time and don't have to start from scratch. Absolutely. And you have your network and your team. So,
and how is basic research happening? Of course, at the university you have labs, lots of them.
Yeah.
Who is working there? Are these doctors as well? And is that a different PhD pathway?
No, it's also the it's the same PhD pathway. So some people, they choose to do more basic science PhD. And there's also, I think mainly in the IBD that's happening also, that you do sort of a combination. That you see the patient in the clinic, but the biopsies that are taken or the blood work are analyzed in the lab. And then there's often postdocs or technicians in the lab that help, of course. But the PhD fellows also do some of the work, and some are more, have more feeling with it than others, maybe. I think the people who do it, you choose what you want to do, of course. But there's also people, like PhD students, working in the labs.
Okay, so this decision has to be made very early in your system. Whether you have a tendency towards basic research and then become a clinician, or clinical research and become a clinician at that very center.
Yeah, I don't think there's a lot of people who start basic research after they have already finished their clinical training. I think if they want to go that way, most of them have started early on.
Oh, I see. So back to you. You did all these studies. You were very successful. You had good publications. That was probably a motivation to go on?
Yes. Yeah, it was. I think the motivation was like the PhD. I just had. You learn so much, and it's really nice to have your own focus and to see what you can do by collaborating. Because we did a lot of multi-center studies, as you know, the fun of collaborating and that you can really achieve something meaningful and relevant. That's very rewarding. And I think just doing the clinical work, for me, it would become, I like the dynamics of also researching something that you then can apply, or that you're working, you have a question that you can look into it.
And also, I think if you're treating patients, you sometimes wonder, do I do any good?
Yeah.
I want to know the outcome. Maybe I have to modify, and that's part of that mentality, isn't it?
Yeah. The patients sometimes ask you questions. So what's my prognosis? What are the chances I will be cured after this? And it's, I think, nice to be able to tell them something, and it's even better if it's your own data.
How it's here in that department. That's what sometimes patients are asking. How are your results?
Exactly.
If you say, well, I don't know, but in that paper from the Netherlands, it's so and so.
Yeah, it's different. Yeah.
It's different. Another issue which is sometimes brought up, maybe that's too much a German perspective, but in Germany, gastroenterology often covers internal medicine. It's very broad. So people are proud of being very broad. So they have the huge spectrum, they can treat all kinds of diseases. Did you ever miss that, or did you enjoy being very focused? You know, it's only Barrett's, it's esophagus.
For me personally, I feel very comfortable focusing, even on those few centimeters, because there's still, if you go into it, there's more and more you can learn and look into. I think that's maybe personal choice. I like to be very focused. Of course, if I'm on call, I have to cover the whole. So we don't do internal medicine in the Netherlands. It's really just gastro. We have 2 years during our training, but after that, we don't do any internal medicine anymore. So if I'm on call, you have to cover everything, which I can still do. But I'm very happy to go back to.
So maybe we shouldn't give a wrong impression. So there is some endoscopy training, right? To be able to do an emergency ERCP and that kind of stuff.
No, I don't do ERCP.
Okay.
Yeah. The interventional endoscopies, like the ERCPs, I mean, then they're covered by a group of interventional endoscopists. So even
it's a separate group on call.
Yeah. So if you're if you have a patient with a cholangitis, I decide if I think they need an ERCP or not. And if they need the ERCP, I call the colleague who's able to do it.
So a very focused system again.
Yeah. And it has to do a little bit with the training, and you have to. If I would do the ERCP, maybe I would have learned, but you don't do that many, and then the chances of complications for the patients are higher. So I think the Dutch system is focused in that way to, give the patients better outcomes.
And everybody accepts. So there's no desire to be the general internist and.
No, I think no. I think some people, they decide they really want to stay broad in the field of gastroenterology. But I think otherwise it's quite accepted that you're more and more focusing. Also because in the gastro, there's so many possibilities and different treatment options. And it's really hard, I think, to keep yourself good at everything, because we just have so many new techniques and new devices. So I think it's also logical that everybody is sort of narrowing.
So better good than broad.
In my
Maybe,
opinion,
yes.
you also need like the foundation or the glue to keep everything together. I think it should be a little bit of a mix. But I think if it comes to specific interventions, it's better if you have someone who's trained and skilled.
So let's assume you're doing the same thing for 10 years, 20 years. What's next? I mean, the next is obviously you are involved in the European Society. UEG, that's a huge task, isn't it? So will that take a lot of your time?
Yeah, it will take more of my time. And I think, but it's a nice new challenge, challenge to learn more management tasks and something different from the clinics, which also always has interested me somehow. And I think having a bit of change of scenery and tasks is good to keep me motivated and to be able to do a nice mixture. So it will cost more time, and so it will mean that I will probably do less clinics or less endoscopy for the time being. But I still have to work for a very long time. So I'm very confident that once this task has ended, that I can pick up the rest again.
And I'm sure you have an agenda. So what should Roos Pouw be associated with at UEG? Training, research?
Well, a little bit of everything. I think because I had, of course, do a pitch and tell what I was going to do. And I think as Secretary General, I think the task is mainly to keep everybody together. I think it's very important in this time. So there's a lot of very quick communication via emails, less face-to-face contact, WhatsApp, and it may become a little bit less personal, and we may lose a little bit of curiosity in each other. So my ideas, what I want to try is to keep everybody connected, to have all the members have a voice in UEG, to stay curious what all the members want, and that UEG can provide that, or at least listen and echo that. And I think what I feel is really important is to have a lot of diversity and role models for everybody, so everybody will feel at home. And I think this is nice because there's already, UEG is very active, they have this diversity board. I think that's something I want to really endorse and enforce to keep that movement going.
Well, I think you are from your multi-center studies, I remember you were visiting us in Hamburg in the days back. You're good in bringing people together. So that's probably one of your many strengths. But you were mentioning diversity. There's women in endoscopy or women in gastroenterology. The situation from this perspective has surely improved. What's still missing? Are there not enough interventional, pancreatobiliary endoscopists, female endoscopists, or what's still missing?
Well, what's missing is, for example, we had an overview of the different boards and committees in the UEG community, and how many the percentages in the different groups were women and men. And what's interesting is that more the softer committees, like diversity, equity, public outreach, etc., there the women are much better represented than in the science, for example. There it was, I think, only 39% or something. So I think it should be more equal in all fields, and the same holds for in endoscopy. I think IBD often is more females are into IBD, and men are maybe more into the interventional stuff, maybe for good reason. So, but I think
that's one of the questions, isn't it? So the hard stuff, the operation, is that really a male thing?
That's what I'm questioning, because I think it's also a little bit a role model thing, because if you only have live endoscopy and then you see men doing ERCP, I think if you've always seen that, it's sort of in your head automatically you get this prototype of an ERCP doctor being a man. And I think that's the thing we need to change a little bit. And I think it's happening. It can happen a bit faster maybe. But I think it's not only that, but it would be very interesting. For example, I think men maybe deal with complications, etc., different as women do.
Mm-hmm.
Not every, of course, it's always difficult to say these things without generalizing everything.
But you have to some extent. If it gets political, you have to generalize.
Yeah.
Even if you know there are limitations and individual exceptions, etc.
Yeah, and I think women may make different choices. And then I think it's important to look at why they make a certain choice. Because if it's like don't go into interventions because of the complications and how they manage, I think that's a different reason than if they say, well, I don't want to do all the on-calls, etc. Because that's something you can change, of course. That's something if it's just practicalities that's holding them back, I think that's something that's changeable. If it's something that you experience differently, it's difficult to change because it's personal. And I think there are differences maybe between men and women, but if it's practicalities, I think those are the things we need to address and see if we can change.
Actually, I tend to compare this with conductors because I'm a fan of classical music, and maybe 20 years ago there were a few female conductors, and not to name anybody, but they were not very good. Now the denominator is much bigger, and all of a sudden they're fantastic people. So there's hope, I think.
Yeah.
You also have a change of your working place very recently, right?
Yes. Yeah,
Can you tell us a little bit?
Of course, yeah. I've been, as I just said, I started in Amsterdam in 2006. So I've been there for a very long time. I did my PhD there, my training, and then I started there as a staff member. So I've been there for a very long time, and I learned a lot. I got all the opportunities I wanted, and the reason I changed, because in January I'm going to work in Utrecht at the University Medical Center in Utrecht, is that the Amsterdam hospital became quite big. So the two academic hospitals in Amsterdam, they merged to one center. It was decided by the governing board. So we have a beautiful new endoscopy unit with 9 state-of-the-art endoscopy rooms and really big team, very specialized in different areas of gastroenterology. But I felt, for me personally, I think I prefer working in a smaller team. We have about 30 colleagues now, and everybody's great personally. But I think as a team, it's more challenging to keep everybody together, especially if you come from 2 different universities and that has to merge. And I still have to work quite a long time. So I thought there was a great opportunity coming by, and I thought, well, maybe it's good just to try something else and see if I enjoy working with a smaller team better. And then I thought, why not?
Maybe there has to be at least one change during your career, right?
Yeah.
To have a new environment. It's the same country, the same system. So it would be harder if you went abroad and had to be accommodated and acquainted with a different medical system. Because a lot of things are sort of subconscious after some time. You know whom to address, etc. Oh, okay.
Yeah.
So from our side, of course, all the best. The final question, your life outside of medicine. I see on LinkedIn you do a lot of sports.
Yeah. I like to run, and this sort of started. So I have to say I did a lot of sports in the past. I have 2 sons. They're 9 and 11 right now. So now they're at an age that they're more. They will not die if I leave them alone. My husband also is very supportive and takes care of them a lot. But when they were younger, it was very difficult in the weekend to do sports or anything. So I did a lot of sports, and then I did nothing for a couple of years. And then it didn't feel really comfortable, so I started picking it up a couple of years ago when they were a bit older. And I cycled a lot at first. I loved it. You can cycle around the Netherlands very easily. It's very flat. You can go everywhere very easily.
Like in Hamburg and surroundings, yes.
Exactly. But I travel quite a lot, and you cannot take your bike everywhere. So I picked up running because it's very easy to just take your shoes and you go for a quick one. You're fresh. You've moved. And it's also sort of challenging just to see how far you can go and run a bit further and a bit faster. So, and it's easy in the weekend. I just put the kids behind the TV
so
and
maybe
go running.
we didn't think about that, but for the ergonomics of endoscopy, maybe it's better if you do sports, right?
Definitely.
Nobody has looked into that.
Yeah.
Maybe a running endoscopist has a better life and less back pain or whatsoever.
Yeah, I'm convinced by that because you get more core strength. You have a better posture, I guess, and endoscopy is very static, so you don't move much. And then I think with all the new knives, etc., the only thing you do is move your fingers, your hand, and you tap your feet.
And you might be very tense in most parts of your body, and that you don't realize.
And a little bit of movement is good.
Isn't that a very nice conclusion to that podcast?
I think so. Everybody should go run.
Everybody should go run. Okay. Thanks very much, Roos. It was a very nice podcast. Thank you.
Thanks. I enjoyed it.